sepsis. Some people then use 3 days, which then they say is hospital-acquired infection in neonates. Now, if you look at the definition by the Europe CDC in their point prevalence survey of healthcare-associated infection, it's interesting when you look at how they define healthcare-associated infection. So if we look at it on the next slide, how they define that. So they define that an active healthcare-associated infection is when you have symptoms present on the day of the survey. It's defined as follows. An infection is active when signs and symptoms of the infection are present on the day of survey. Date of signs and symptoms were present in the past, and the patient is still receiving treatment for that infection on the survey date. The presence of symptoms and signs should be verified until the start of the treatment in order to determine whether the treated infection matches one of the case definitions of healthcare-associated infection. And so what I want to highlight here, looking at the underlined sentences, the onset of symptoms was on day, if the onset of symptoms was on day 3 or later of the current admission, or the patient presents with an infection but has been readmitted fewer than 48 hours after a previous discharge or transfer from a healthcare facility. I'm bringing this up because a number of times patients that have been in hospital, they get discharged and they get sick and they come back, and then you will often say it's a nosocomial infection, even if it's after a week or after 7 days of that. But here they are looking at 48 hours. But if you look at that second bullet, for patients who had surgery for surgical site infection, then that period is much longer, as 30 days post that surgical procedure. And then they say for the other surgeries and have like implant, that goes up to 90 days. Now, if you look at newborns, at neonates, that's the second last bullet, they talk about onset of symptoms on day 1 or 2 in a newborn that could be considered as active healthcare-associated infection. So the question of in neonates to say when do we call an infection hospital-acquired infection? So you can see it could be day 1, day 2, day 3, depending on who are you looking at and which paper you're looking at. Now, here I'm sharing our experience at Bara. We just look at the last year, beginning of the year. We looked at day 0, that means the patient at birth, and we use ampicillin gentamicin for what we call early onset sepsis, which means, again, we use the first 3 days of life. So when we give ampi and genda, so the organism that we grew, we had 5 patients with positive cultures over that 6-month period. And of those patients, the one with 3 had enterococcus. 2 of those enterococcus were sensitive to gentamicin. So which means the other one we're not covering one of the patients. The group strep is good, had only 1 case, but 100% sensitive. And Striviride and strep was sensitive to cefotaxime, which we don't use routine as a first line. But you move on then to day 1, and you see that on day 1, you found a lot of babies who had positive culture. That means these patients on day 0 did not have signs of sepsis. On the following day, they had signs of sepsis, and then blood was taken for culture. So you can see then that Enterococcus faecium, Enterococcus faecalis, gentamicin, they were all covered by gentamicin, which is fine. But then if you look then on that day 1, we had 2 cases of Acinetobacter baumannii and 2 cases of Pseudomonas aeruginosa. And those patients, only 50% of them were covered by gentamicin. So by day 1, you're already struggling with what we call empiric treatment for patients with what we call early onset sepsis. By day 2, well, day 3, which is, day 2, if you look from day 0, gentamicin, again, we could see there 12 of patients were positive culture at APOMAN. But of those patients, if we're still using ampi and gentamicin, because we're recording hospital-acquired infection as that happening after 72 hours. A lot of patients will not be covered by ambient gender. As you can see, only 16% were sensitive to gentamicin. So we had a Pseudomonas that was fine. So what I'm highlighting here is that this definition of hospital-acquired infection using 3 days and more, we're going to have a problem in our situation where the incidence of sepsis is very high. So I think, to me, there's nothing stopping a baby who's at delivery being exposed to whatever in a bed or in maternal bed or in a neonatal bed, being exposed to that infection that is in the hospital and showing up with signs the following day. There's nothing stopping us to say you cannot get what is in your unit as compared to having acquired it from the mother. So as you can see then, look at those definitions, it becomes then difficult to give a true estimate of healthcare associated infections in our units, because it depends. What are you using as a numerator? What are you using as a denominator? Some studies use live beds, some people use admissions, some people use patient hospital days. I think, to me, using live beds it's not the best way to do it, because a lot of live beds would have gone home. But I think one should be looking at admissions or patient hospital days and not live beds. Now, so there's a paper coming from, led by the colleagues from NICD as part of GEMS, where they look at the burden of sepsis. If you define then what we call a hospital-acquired infection, similar to late onset sepsis, and early onset sepsis is 0 to 2 days, 2% of neonates who've got infection actually have got hospital-acquired infection or late onset sepsis. So you can see then what we call hospital-acquired infection is a major problem in terms of what we're experiencing in the facilities. And then again, from this study, you can see the major contributor, if you look at the national level, that the national central hospitals, which most of the time are the so-called academic hospitals, and the regional hospitals, contribute significantly to a number of neonates who got sepsis in the country, and then followed by the provincial tertiary hospitals and the district hospitals. Now, when we talk about healthcare-associated infections, we talk to all the infections. We talk about bloodstream infections, pneumonia, UTI, meningitis, NEC, soft tissue infections, and others. But in this presentation, I'm going to focus more on the bloodstream infections, because that's where most of the time the problem comes from. Now, this is looking at all patients, including the adults, again, using the same definition of 2 days. Here, what I'm trying to bring up is that if you've got a patient with a positive culture and you repeat that culture, or your patient gets sick again in the next 7 days, some people will call that as the same as a one episode. So that means if you have infection and then that patient gets better, or get another infection, doesn't get better, and you have another positive culture within 14 days of the original one, some people will call it still a same episode of infection, which again becomes a problem in terms of looking at the incidence of infection. So some people will say you only use that 14 days if you keep on growing the same organism. But if it's different organisms, then some people then will use a different 7 days instead of using 14 days. So that's another way of looking at the organisms in terms of the defining healthcare-associated infection. But where you have commensals like coagulase negative staph, then one would like to have 2 positive blood cultures with at least one sign, and usually within 48 hours of each other. So again, in the same paper, looking at the different ICUs in terms of the the infections. As you can see, adults aside, that's where you have a lot of problems in terms of CLABSI, and as compared to neonatal ICU. I suppose neonatal ICUs we do use central lines, but not much as in pediatric ICUs and adult ICUs. So as you can see, in terms of the CLABSI is more higher in the pediatric and adult group. But if you look in neonates, then we see the 87% of neonates with positive cultures are usually not having central lines. It's because I think we're not using not many babies are having central lines. And again, here is just to highlight that looking at the different age groups, the patients who seem to having a lot of bloodstream infections is the lower birth weight babies, especially if looking at 750 grams. So I think the colleagues who are in the private sector who've got more experience with these babies, especially in ICUs, you might expect to see more babies with bloodstream infections in the lower weight categories when it comes to neonates. Now, when we talk about infection, we talk about bloodstream infection and looking at the positive culture as a determination of that. We just need to remember that the yield in terms of cultures is very low. This is a study coming from the Western Cape, I think it's from Tigerberg. You can see the yield of positive culture is less than 20%, but does not mean the ones that are negative are not having sepsis. So I think a lot of sepsis is culture negative sepsis. So we need to be careful when we're looking at diagnosing sepsis, that if you still have clinical signs, look at other biomarkers in terms of looking for infection rather than relying only on blood cultures. Again, here, this is just highlighting the problem in terms of the weight categories. And you can see on this paper that the babies who are smaller are more likely to have sepsis than the babies who are relatively bigger. I think part of that I will cover on the next slide as to why those smaller babies might be coming with sepsis. Now, so the risk factors, again, in terms of looking at why that weight category, the lower babies or the babies who are more preterm are more likely to have sepsis, again, is immature skin in terms of the innate immune system. And also, of course, even the adaptive immune system is underdeveloped. And again, more important is that most of the time, these are the smaller babies who are more likely to go on ventilators, having umbilical lines, to be on TPN, to be getting prostrum antibiotics. So all these interventions that we do to save these babies, we need to also be aware that the risk of infection goes even higher. In our settings, again, I'm not sure about other hospitals, but in my hospital, we have a major problem in terms of overcrowding and also higher patient to nurse ratios, what means few nurses looking after critical ill patients is a major challenge. Now, this is just looking at these factors that I've mentioned, that if you look at a patient with a lower birth weight category, the odds of having hospital-acquired infections are threefold. The same for the gestational age, the mechanical ventilation, and that if you put an IV line, the odds are threefold. And if you've got a baby with feeding intolerance, the odds of having hospital-acquired infection are twofold. So looking at, sorry, these are relative ratio, not the odds. So as you can see on the last column, the relative risk, you can see is 3 times the risk of this patient having infection when they've got those characteristics on the first column. And again, this is significant because most of them are not including the number 1 in the 95% confidence interval. So these are the risk factors shown in this study. Now, how do we then suspect that these babies are having infection? What are the clinical signs that we should be looking for? Again, this is the study that came from the World Health Organization, looking at, called the Young Infants Clinical Science Study. So you can see that if you got a baby who's got a difficulty with feeding, and especially if the baby's been feeding okay before, and this has got a feeding problem, whether it's got a distended abdomen or it's having is vomiting. So you should be worried, because you can see all those different signs. Movement only when stimulated, lethargy, hypothermia, high temperature, problem capillary fluid time, the fluid rate, although the fluid rate is questionable sometimes. Cyanosis, severe chest syndrome, history of convulsion, hypertonia. All these signs were related with the odds of these babies having infection. So these are the signs that we should be thinking of. As I say, one sign sometimes is not might not be adequate. You might have to look at other signs, and again, some other signs might be related to other factors. For example, the temperature could be related to the environment. So we also need to say, why we're looking at these signs, let's look at other factors. Convulsions could be related to intrapartum hypoxia, not necessarily infection. So we say it's not just one signs, but these signs, to me, you must be alert that you must be dealing with your neonate with infection. Now, so having looked at those signs are suggestive of infection, but they're not specific for infection. So that's the major challenge in neonates, that the signs are not specific for infection. These signs could be due to other things other than infection. So then how do we make a diagnosis then of infection? So the gold standard at the moment is blood culture. Sure, there is PCR, but I think the PCR is still a challenge in terms of cost and availability and what it means if you got a positive PCR. So the culture, the problem then with the culture, that the yield is low, as I showed you in that paper from Western Cape, where they showed that less than 20% of the cultures were positive. So the yield is very low. But I think once we're looking at that, we need to be careful that the yield is low, but there could be a lot of patients with growing coagulase negative staph, which in some places people treat. In our unit, we don't treat regularly. It depends on other factors. So it's important as to how we're taking the blood culture. So we need to make sure that we clean properly. And we have the common problem is that you clean and your hands you have washed and you use that cotton wool to clean, and then you go and palpate and fill that vessel that you can take the blood. So you can then have a contamination. And then also the results are affected by where you're taking your blood from. If you want to take from the central line, there could be a problem of contamination. But I think more importantly is how much volume you're taking for that culture. So there's a study that's shown that if you're taking 0.5 mils, the probability of getting positive culture is 39%, even if there's a pathogen in that blood. But if you take 1 mil of blood to send for culture, then you improve that detection by 3% if you have one colony forming unit in that blood. But if you take 3 mils, the probability improves up to 95%. So the recommendation is that when you're taking blood for culture, we should be taking at least 1 mil if we want to improve the chances of picking up the organism if there is one, if there's an organism in blood. So in the absence of ideal test, which is you want a test that is 100% sensitive, especially a condition with such a high mortality. What do we have? We have a full blood count, we've got a C-reactive protein. That's what we use in our hospital. And the procalcitonin, we don't use it that often. And I think partly because of the cost that comes with procalcitonin. So if you look at any different studies, looking at the absolute white cell count, again, people use different values. Not absolute white cell count, the total white cell count. If you look at the total white cell count, which maybe some people say from day one is 9 to 30, and then subsequently to that is 5 to 25. The sensitivity is very low. So white cell count is not that helpful in terms of diagnosis infection. And the specificity is 99%. If you do use a white cell count, to me, there's no point of doing a full blood count without asking for a differential count if you're looking for sepsis. Because your white cell count might be normal, but a neutrophil count might be relatively helpful than the total white cell count. So the absolute neutrophil count still has low sensitivity, because you can see it's far from that 100% of an ideal test, but it's better than the total white cell count. And then the other one that gets used is the immature to total neutrophil count ratio, which is 22 to 54%. But that test of immature total neutrophil count is much better if you're doing a manual count than if you're using a Coulter count. So that, again, the yield is better than total white cell count. And then again, the platelets that we often use, the sensitivity, again, is relatively low. So you can see the full blood count that we use is, for depending on what parameter you're looking at, it's not that great to diagnose infection. C-reactive protein, better than full blood count, using more than 10, because looking at the studies, the range is from 6 to 88%, but generally, we're looking at about a sensitivity of 70% and the specificity 3%. Procalcitonin, if you look at using a level of more than 2, again, better than CRP, 9 to 100%, on average 92%, and the specificity, but it's a bit on the lower side. So in short, we need then to say we are going to do blood culture, but the blood culture, if it's negative, does not exclude sepsis. Then what other things that we have? Then there are these tests that we have here, full blood count, C-reactive protein. But we're talking in a patient who's got signs suggestive of sepsis. Now, what are the organisms that are causing sepsis? I think generally depends where you are. If you look in the developed countries, on your right, on the right side, you can see this is a study coming from Netherlands. You can see if they look at labs, 90% gram-positive PBSI, that means a positive bacterial cells infection is 87%. And then the bloodstream infection is 59% are gram-positive. Whereas if you look again, this is a study from Tigerberg, 51.9% are your gram-negatives. And then again, a number of them are polymicrobial, which is a misgrow. And then your gram-positive come to 34.6%. Again, just to highlight here, again, as you can see in this paper from Tigerberg, you can see gram-positive is Staph aureus, Coagulase negative is 5.6, whereas you can see in Netherlands, they put Coagulase negative Staph high as a causative pathogen. So we have then the clinical presentation, and then we have the test that we do to make a diagnosis. But when these patients are so sick with high mortality, it's difficult to wait until you get the culture results, which I say might come back negative. So most of the time, you'll start them on empiric treatment. So that means it's not a prophylaxis, it's empiric, because you're saying clinically in this patient got infection. But I'm going to give antibiotics to cover what I think is most likely. So then if you look at the EDL, the South African guidelines, I think there'll be neonatal guidelines coming up soon. So what is in the EDL is that then empiric treatment should be piperacillin combined with tazobactam, which we call, in short, usually called tazocin, and add with amikacin. So that is what is looked at. Again, once you don't have the important thing, you start the empiric treatment. You look at the clinical status of the patient. If the patient clinically is improving, the other markers come back negative, and the culture is negative, we should be stopping antibiotics by 48, 72 hours, because if the culture is going to be positive, most of the time, by 72 hours, is positive. And it's going to be positive if there's a pathogen. Unlike, well, they can still have some positive after 72 hours, but most of the cultures, if they're going to be positive, most of them are positive by 72 hours. So where you have a patient with clinical signs that they thought was sepsis, and the patient clinically is doing well, and the markers come back negative. I mean, always people debate what if it's getting better because of treatment. But I think some of the signs, you're starting with a low probability, of course, but because people are scared, they start the antibiotics. So this is what is recommended in the EDL. Now, but the problem is that we're dealing with organisms that are resistant to a number of these pathogens. So this is a study that comes from New Delhi, where they show that, again, the common organisms were the gram-negatives, but most of the gram-negatives were resistant to the common antibiotics that's supposed to be covering them. Now, similar study which included sites from South Africa. Again, the organisms that were grown in neonates are resistant to the common antibiotic that we use, including the cefotaxime, ampicillin, ceftriaxone. So we need them to be aware of this. So this is a South African study looking at the neonatal bloodstream infections and meningitis from 2014 to 2019. So you can see again the common organism from this paper from South Africa is Klebsiella A. baumannii, were the common gram-negatives, and then for the gram-positive were the Staphylococcus aureus and Enterococcus. Again, if you look at coverage, ampicillin and gentamicin, which we use as for early onset, is coverage is not that good. And then if you look at the peptides, you can see if you look at on the graph on the right side that the susceptibility of the organism is reduced over time. If you look at 2019 as compared to 2014, but of concern is also the meropenem. As you can see, the susceptibility decreased from 84% to 67%, because meropenem is another drug that for a second line or for hospital-acquired infection, we do consider, especially for Klebsiella A or gram-negatives that are ESBL producing. So we are in trouble then, looking both at international at a national level, because if the peptides and meropenem, the resistance is increasing or the susceptibility is decreasing, we are in trouble. Again, just sharing our experience at Baragwanath Hospital, again, looking at the first 6 months of last year, where we had about 136 isolates of Klebs pneumonia and 126 with A. baumannii, and then Serratia 41 and Pseudomonas 17. Those are the gram-negatives. And our first line is peptides. We combine peptides and amikacin. So when we combine peptides and amikacin, we've got Klebsiella pneumonia, and these are the ESBLs. So the amikacin has some coverage. We can see about 79% of those were sensitive to amikacin, but only 47% were sensitive to peptides. Now, if you then look at abomani, only 2.4% are sensitive to peptides and 12% are sensitive to amikacin. So looking at these common pathogens in our setting, Klebsiella and abomani, the peptides and amikacin that we're using is not adequate. And also, even if you look at meropenem for abomani, it's not good enough. So it's a bit better. Well, if you say 35% is something better than nothing. So cefepime and ceftazidime, some of the abomanis are sensitive to that. So when you come to the gram positives, then as you can see for the staph, we're dealing with MRSA most of the time, but we have not had MRSA that is resistant to vancomycin. So we've got all of them sensitive to vancomycin. Now, in terms of the problem of hospital-acquired infection, it's not only death, but it's also the other complications that come. And that include that these patients have to be on antibiotics. You've got a prolonged duration of stay. Severe IVH is a problem. NSC and chronic lung disease. So if you look on the second column, where you've excluded hospital-acquired infection, if you look at these morbidities or mortalities, you can see, if you compare the patient who does not have infection and the one who's got infection, looking at mortality, 28% of these patients died compared to 5% of those who did not have mortality. And if you look at conditions like cystic PVL, with neurologically long-term but poor outcomes, you can see 11.6% of those with hospital-acquired infection had PVLs as compared to 2.8%. So what I'm highlighting is that the infection is not only a problem in terms of mortality. Even those who survive, we should be following them up because they can have other morbidities. Now, if you then look at the mortality in terms of sepsis, if you've got sepsis and you've got severe sepsis, then the mortality goes up significantly, especially in the upper middle income countries or lower middle income countries. One could argue South Africa is somewhere there in the upper middle income countries, but relatively the mortality is worse in the lower middle income countries. But if you look at a patient who's got, this is the first one is sepsis mortality, this is severe sepsis. And if you've got a patient with sepsis and septic shock, even in high income countries, you can see the mortality is 20%. And then that goes up to about 40%. And then in low middle income countries, that mortality goes up to more than 40%, 40 to 60%. So sometimes how they present these patients is associated with high mortality. So in our setting, what we do then, if we've got a patient who comes in with a septic, who's presented with what we think is sepsis, and it's got hypotension, is septic, we would go on straight to meropenem. Whereas for some cases, we would start with tazocin and amikacin. And exactly because of this fear that once you've got septic shock, most of the time you've lost the boat. Now, the other important thing is that we prescribe antibiotics. It is important that once we prescribe the antibiotics, once we pick up that the patient has got sepsis, we should not wait in terms of starting antibiotics. Start the antibiotics as soon as possible. So in this paper, they've shown that if you take longer to administer antibiotics, they are looking at every 30 minutes increments. The 7-day mortality is 1.2. But if you look at the 14-day mortality, that one is also high, but if you look at the confidence interval, include the number 1, so not statistical significant, but the 14-day mortality, 30-day mortality, it increases. And also, if you start the treatment early, less likely to use to require inotropes. So the message here is important that once you diagnose, once you suspect the infection, you take your bloods, especially the culture, and you start the antibiotics. The sooner, the better. Again, this is just emphasizing the point, is that the longer you take to give antibiotics, they increase the probability of the 14-day mortality. Now, so we often start patients on empiric treatment. Again, it's a major challenge for us, where you have shown you that the A4 which is a common gram-negative that would grow in our hospital, is resistant to peptides and amikacin, also resistant to marrow. Then the temptation is to go to colistin. And again, it's a difficult thing to do because colistin is the last line of defense. You want to reserve it. But in this study, what they've shown that if you start them on empiric treatment and the culture comes back positive and there's discordancy, that means the empiric treatment that you used is not covering the bacteria that will grow in the blood culture. The mortality is high when your empiric treatment is not the right one. So that, which is a big challenge, is that then when you've got a common A4, is empiric treatment not better to be colistin rather than to be meropenem or tazan amikacin? But again, there's a problem there, because if you want to do that, some of these patients actually might not be having the infection or might not be growing the A4. So what I'm highlighting here is that your empiric treatment must be informed by what are the pathogens or organisms that you grow on your babies admitted to your unit, rather than using what I'm quoting here or what I'm talking to based on our experience. Don't say in that hospital they're using this, but you need to be having surveillance in terms of what are the organisms that will grow in the unit, so that when I'm having a patient with a suspected sepsis, I would say commonly these are the pathogens or organisms that will grow in our unit, and therefore I'm going to choose an antibiotic that is going to cover the common organism that will grow in the unit. So it's important that we try the best to say, when you're giving that empiric treatment is most likely to cover the pathogens or the organisms that are the common cause of infection in that specific unit. Although most of the time when we talk about sepsis, we talk about mortality. As you can see, many studies, if you look at the bottom numbers, many studies are reporting on mortality, morbidity, and other clinical outcomes. But there are very few studies that are looking at neurodevelopment. And I think this is one area that we should be looking at long-term as to how many patients survive with sepsis, and of those who survive, how many have impaired neurodevelopmental outcomes. So I think the follow-up is very important in terms of the patients we have with sepsis, who survive sepsis. So as you can see, we are struggling in terms of the organisms. We are struggling in terms of having the right diagnosis. We're struggling in terms of getting the right antibiotics. So what is how do we deal with it? I think, to me, the main thing, and I think not to me, to all of us in this webinar, we would all agree that the best thing is prevention. We should be making sure that we do not have the infection at all. And of course, the first thing is to make sure that there are no babies who are at risk, and that includes no preterm beds. So if we make sure that there were no preterm beds, that will go a long way. And if they are born preterm, then we need to give them what will reduce the risk of infection, which will include breastfeeding, reduce the interventions, only if it's really, really necessary, and be alert. But of course, on top of that, the hand hygiene is important in terms of alcohol-based hand rub. And I think the mothers must be part of that in terms of education. The equipment that we use, we need to make sure that is properly cleaned. The environment that we are in and working around must be properly cleaned. There need to be some standard operating procedures as to how to clean the environment, how to clean the equipment. And once you have that patient who's got infection, try to minimize the spread of that infection, especially if you're dealing with the infection that does not have treatment. There are no antibiotics to use. So we try and make sure that you isolate those patients. So again, in the unit, we've got a major problem of sepsis, but number two, we've got a problem of space. So having those different infections isolated in different cubicles is often a challenge. So now and then would lump them as those patients with risk of infection. For example, we have an approach that says the patient with CRE, that means penem-resistant Enteropathuralis, and Acinetobacter baumannii, that is resistant, is only sensitive to colistin. We'll put those patients together. So what we call CREP, penem-resistant baumannii, and CREs, we'll put them together because the only treatment that they are requiring is colistin. So we'll put those patients in isolation separately as a group. And then the other group of patients that we will try to isolate before were Candida parapsilosis, Candida albicans. But again, in our unit, those Candida species have been overtaken by Candida auris. So we'll end up now targeting then that Candida auris in terms of isolation. So we've got a cubicle or an area for Candida auris, and we've got an area for the CREs and the CRAB or CRAB. So that's isolation that we have. But otherwise, the others, we try and isolate them where they are, where we put a tag, a red tag that this patient is infected, and for the precautions in terms of isolation should be followed most of the time is conduct precautions. So in conclusion, I just want to highlight that healthcare associated infection remain impairing cause of morbidity and mortality, therefore a threat to human survival. And I think the prevention is the main thing in terms of us reducing the infections. But if we've missed the boat, you did not manage to prevent them, we pick up this infection, then either administration of antibiotics is important. And of course, we need to be aware as to which neonates are at risk of infection and pay even more attention to those babies. I thank you.
Thank you very much, Prof. Velaphi, for this very extensive, informative presentation on hospital-acquired infections in neonatal units. And I think you've covered it so well with examples of where you've been, what you've seen, especially in the public sector and the different levels of hospitals, and also compared with what we see. It's interesting that you were showing that somewhere in Europe, we've got more gram-positive than gram-negative, which we have. And I suppose this gram-negative and positive, it's both in the public and the private sectors, though you didn't have presentation with what we see in the private sector. I don't know if you've got any comment on that.
Sorry, come again?
No, I was saying that I was seeing the comparisons that you're showing that if you can just end your slideshow because I can't see myself what I'm properly.
Okay.
That in somewhere one of the countries in Europe, you say that there's more in neonatal units. There's more gram-positive compared to gram-negative in our settings in the country. And the second question was in terms of this is a general presentation that you've shown of the public sector, but does it also correlate with the private sector? And I know that you did mention that in the private sector, they see because of the low birth weight that because of the policies that we do see more of low birth weight admissions in the neonatal units in the private sector, and hence the infections could be much higher.
Yeah. So I think in terms of the private sector, I hope the colleagues from private sector are in the meeting. They will comment better on that. But my understanding is that they are dealing with the similar kind of problems, even in the private sector, in terms of the gram negatives. Regarding the coagulase negative staph being common in the developed countries or in the high-income countries, I think it's possible that it's also common even in our setting, but a number of times in our setting is related to contamination in terms of the cultures. Whereas in that setting, things are done strictly. Some people would even put on gowns and all that when they are taking the cultures. So not that coagulase negative staph cannot cause infection in developing countries. It can cause infection, but I think the challenge is that quite a number of times is related to contamination, and also it also depends how you define the infection due to coagulase negative staph, because most of the time some people will then look at what other signs you have. For example, in our setting, if you've got thrombophlebitis or cellulitis, and we grow that coagulase negative staph, we might be more likely to start that patient on vancomycin. But in the absence of those, then usually we'll repeat the culture within 48 hours. Then, if that culture is positive, then we will consider. Or if the patient is not responding on the current antibiotics that you've started the patient on, and you're growing coagulase negative staph, then that will be another time where we might consider adding vancomycin.
Okay. Now, in terms of when do you think, are there studies that indicate if, because there was heightened awareness of hand washing, hand hygiene, and purely environmental care during COVID, did we experience a fewer infections, hospital-acquired infections during that period, if any studies were done?
Yeah, I think some papers have shown no change in that. Talking about our experience, but our experience could be affected by other things. We actually saw an increase in the rate of infection during the time of COVID. But of course, there were other factors that could have contributed to that, because for some time, mothers were just coming and visit in and out, whereas before, the mothers were coming in and assisting with looking after their babies, and also including the preparation of the milk and the feed, and also including the equipment that we use. For example, in incubators, the mothers will be the ones who are looking after those babies. So we did see an increase in terms of infection. Okay. So I think some papers did not show any difference with the hand hygiene. So hand hygiene it definitely plays a major role. But I think you reach the extent where you say, I've covered everything, but you still see infection. So hence, even in high-income countries where the hand hygiene is strictly observed, they still see infection. So in other countries, the way that they've reduced infection is where you've got one baby per cubicle. And also the nursing staff, you've got one-on-one, especially for the sick patients, where you've got these invasive procedures. So I think the overcrowding and being understaffed does contribute to the incidence of infection.
Yeah, that's a hard one to manage. I know that in the public sector, overcrowding can be quite a big problem. And the understaffing in the private sector also can be a problem. In terms of, there's a question from Sinas Kumalo with regards to able money cultured on day 1 and day 2. Can we conclude that the babies came with the infection from the labor ward?
A good comment. Yeah, I think you cannot exclude it. I think there's nothing stopping that baby getting that able money from the maternal bed or from the bed in labor ward, if that bed has got able money. So yeah, it's possible. I mean, it's difficult to say where it is. I mean, it could be even our own nurseries, because some of these babies, they get born and they go to our nursery. Some of these babies require surfactant. So if our laryngoscopes that we use are not properly sterilized, or when whatever procedures we're doing, we're not observing strict infection control measures, they might be getting that infection even from day 1. So it's very difficult to say from where. It could be anywhere. I mean, Prof. Martin's unit some years back did a study looking at colonization in the genital tract of mothers who were delivering at Barra, looking especially at gram negatives. They didn't see much in that group of mothers other than the GBS. So, but I think it's a study that needs to be repeated in terms of the source of the able money. So I think it would be a good study to do now to swab the mothers and check if they've got colonized with able money. And of course, some of the mothers deliver after they've been in hospital for some time for different reasons, whether it's being observed for preterm labor or observed for hypertension. So they might have acquired the infection in hospital, which then they can be colonized with that and the babies get it. But I think that will be interesting work to look at.
Okay, yes. And Sithembiso Velaphi wants to know also, or he wants to ask if doing environmental swabs at set intervals has any significance in the neonatal units or the neonatal ICUs.
Yeah, I mean, the question is, you're doing that swabbing for what purpose? So, I mean, when we talk to our microbiologists, they will always say, you do your proper cleaning of the environment, your proper cleaning or the contamination of your equipment, both at the time of discharge or time of death in terms of terminal cleaning. And before you put that patient back on that equipment, make sure that the equipment is properly cleaned. If you do that properly in hand hygiene, of course, you should not be having that problem. So I think, to me, the surveillance in terms of equipment, one might just have to consider when you're looking at the outbreaks. Then you might say, where is the source of that? Just to try and reduce the burden of the infection or of the colonization or contamination in terms of that. Because when you're going to look at the surveillance, are you going to look at the equipment? Are you going to look at the babies themselves? So what we often do during the outbreak, we'll also look more at the babies in terms of colonization, with the aim of cohorting those who are colonized, especially when we have a CRE or see all this outbreak.
I see
But
Dr.
I think
if
there are IPC specialists or IT specialists, I would welcome them commenting on that, on the routine surveillance. But I think doing this routinely, I'm not sure the value of that. The time of the outbreaks.
Just a minute.
But the surveillance.
Donald, please. There's someone, Donald. You can mute him. Donald.
So to me, the surveillance I will talk to is the surveillance of knowing which organism are you growing in your unit. So you should be knowing that you have your culture results on a daily basis, capturing them and knowing what organisms are you having. So even better, you might then have some kind of line listing of the, you might not be able to do all of them, but you can look at target, what we call alert organisms, as to which organisms you think are a challenge or a problem in your area. And those are the ones that you say, I want to know every positive culture in the unit so that I can know what am I dealing with. Not only that, also knowing about their susceptibility. So that surveillance, then to me, if possible, all of us should be running that surveillance in our units. It just helps us in terms of for empiric treatment. That's what we should be starting these babies on.
Okay. Dr. David Tokotane, if you're one of the neonatologists at Dr. SK, that's okay. You understand, you can unmute yourself and just comment, make a comment.
Good evening. Can you hear me?
Yeah, I can hear you loud and clear.
Yeah.
Right. Good evening, Prof. Thanks for a wonderful talk. I just wanted to comment, or rather get your comment on this, because we know that dealing with neonatal infection can be quite a headache, and sometimes a double-edged sword, in that we obviously sometimes don't want to miss infections in neonates, and sometimes we do kind of give antibiotics, sometimes prolonged antibiotics in the neonatal ICU, and that's why I say it's a double-edged sword. You said earlier that the use of PCT, for example, has always been kind of this. It's economically not sound to use PCTs, especially I suppose more in the public sector. But there's obviously studies looking at use of PCT, CRPs, and even the additional benefit of using PCTs in terms of the duration of therapy, which obviously has economic benefits in terms of patients not necessarily having to complete prolonged courses of antibiotics, but also has improved mortality benefit as well. So I just wanted your comment around that, whether, and also the use of combined markers and scoring systems for identification of sepsis in neonates. Thank you, Prof.
Yeah, thanks. So I mean, there are a number of scores that have been used to diagnose sepsis, but I think they have not been helpful in some settings. I think one of the colleagues is in Tylerbeck is doing the PhD, looking at the use of scores to diagnose infection. And I think there's a study called NeoOps, which looked at infection in about 19 centers in about 6-7 countries, and I think 3 sites in South Africa, where they show that if you put some scores together, they might predict mortality at 28-day mortality if you've got a certain score. So it's called a NeoSEP score. So you could use those scores to diagnose infection, but on their own, not that reliable. Now, in terms of use of CRP, so I think if you've got a CRP and PCT, I think if you've got a patient that you think is got sepsis, and your markers like CRP come back normal, and you're convinced that this patient has got sepsis, I think to me, if you're conservative, then I think definitely I would go for use the PCT, the procalcitonin. So again, you can also use it as a first line if you've got the resources. Now, the other thing that I did not cover is the duration of treatment. Well, I did cover partly that. Well, the young people don't listen. You mustn't listen to this. For the people who've got new cars, a friend of mine once told me that the best thing that you can do as a driver is that on the road there are a lot of risks. You go in and get out as soon as possible. So that means you must drive fast and get out. But I think to me, even better, don't drive, don't get onto the road. So the same thing with antibiotics. You think there's infection, everything comes back negative and the patient is getting better. Stop that antibiotic as soon as possible. And I think the practice that we often see, that babies are left on antibiotics for days and days because people are scared. What if? No, I think that's a wrong use of antibiotics. Once you've got the clinical signs that baby is improving and you've got your cultures negative, look at other markers. If those markers are negative, stop antibiotics. Now, if you've got a positive culture, it depends where you pick that culture from. If the culture is a gram-negative meningitis, sure, in that situation, you might have to treat for 21 days. If it's pure bacteremia, then you might then look at 7 days. Some people say 7 to 10 days. Or things like then pneumonia plus bacteremia or plus positive culture. Some people might talk about 10 days or 10 to 14 days. So it depends in terms of that, what you're picking up. But regarding the CRP, some studies have shown that if your CRP was high, you can use that CRP as a marker of response to your treatment, where that your CRP is getting better and is coming down, and clinical, of course, the baby is getting better. Then you can use that CRP as a guide to stop treatment. The same applies that the first CRP for diagnosing or treating infection, the first CRP might be normal, but if the patient clinically has got signs that you're strongly suggestive of sepsis, a serial CRPs might be helpful in terms of picking up the infection, because your initial CRP might be at the early stages where your initial CRP is normal, but when you repeat it, it's increasing. In that situation, you might say, even though the culture is negative, then I would treat the patient with infection as having infection.
Okay, thanks, Dr. Robertson.
I'm not sure if that covers your question, Dave.
It seems to be covered. He's not responding. Thanks, Dr. Robertson. We'll have this as the last question from Dr. Mashiro, one of our regular participants. And he's asking about escape. I think those interlocutors for multiple organisms there. Will it be the ones who are causing outbreaks in our clinical settings or neonatal units?
Come again?
The escapes, I had to check all these organisms that he mentions. Are they the ones who are causing the outbreaks? Is it all of them or just one or two causing outbreaks?
It could be any of them in that group. So, I mean, that escape is just an abbreviation of the different organisms. Yeah. For example, Klebsiella, Pseudomonas. So it's just a group. It could be any of them. So it depends on where you are. That's why you need to look in your unit, because it could be any of those. So, for example, for us in that escape, the things that will come in will be the Klebsiella, and then in terms of the Acinetobacter, and then E. coli will come in, of course, and enterococcus in terms of the gram-positives and stuff. So it could be any of those in that group. So that escape are the most common ones in terms of what you would pick up in terms of the positive culture, but not to one organism specifically. It could just vary from one place to another. But generally, if you look at the gram-negatives, I think for us, we've got the top 4 in terms of the gram-negatives, which will be your Acinetobacter, Klebsiella, Enterobacter, Cloaca. Yeah, so that's the common one. And then we'll then have Pseudomonas and E. coli. So those are the ones that we'll be looking at. And then in terms of the gram-positive, then we see Enterococcus, both fecalis and faecium, and then of course the staph, MLS most of the time. And then coagulous negative staph is the one that I say is dubious, could be a contaminant, it could be a pathogen.
Yeah, but I think, thank you very much. Well, it reminds me, I think the one I mentioned earlier on, when I said in the late 90s, I think it was the late 2000s, I think 2008 or so, when that, I won't forget it, that A. Bomani outbreak at the neonatal unit at Byron, the neonatal ICU unit. You remember that it was quite a big one. Of course, most problems for us in management at that time.
Yeah, I mean, that's one of the painful things when you have an outbreak, is that everyone goes for you. I think as we're speaking now, we just came out from a meeting where we just received a question from the legislature on a number of things about neonates. So that hasn't stopped, Ray.
It hasn't stopped.
It hasn't stopped now. We answered one from the national parliament. Now is the provincial parliament and the media last week. So it's part of the game. But for the infection, it's even worse. It comes up now and then, especially with the outbreaks.
Yeah, I think just a matter of working together with clinicians and administrators in management.
Yeah. I think that comment is critical, because a number of these prevention measures, we can reduce the rates of infection if the management or the politicians can assist us. I mean, for example, if each and every mother who delivers preterm or who's got a baby in hospital gives breast milk 100%, that will go a long way. But it's often a challenge when you don't have a space for those mothers. You don't have a larger facility. You don't have adequate KMC. You don't have a milk bank. So which requires some resources to be put in place. And that requires the administrators or management, they're putting more resources and funds from the politicians, and funding and support from the politicians. That's where the budget comes from. And also, of course, having said that, in terms of the prevention, the question of infrastructure, the space for these neonates, the question of number of nurses, the number of doctors who are looking after these babies. But I think if we can bring in the mothers and stay with these babies and give breast milk, will go a long way. So I agree with you. Working together as clinicians and administrators, talking to each other, helping each other. I know at management are also having challenge in terms of resources, but I think there are some minimum requirements that we should try and meet, especially looking after the neonates.
Yeah, definitely. Yeah, I agree wholeheartedly. Yeah, we've come to the end. I see Dr. Mashiro's hand is up, but we ran out of time. What I'm going to do, Dr. Mashiro, I'm going to ask you to do the closing remarks, and then you can make your comment as you do the closing remarks. But that's, and then thank everybody who's been here. Very short.
Yeah, just a quick one. I mean,
just close here. Just quickly and close.
Prof, I just want to inquire here. Have you seen any cases? I mean, presenting with a Candida aureus? I mean, we know what is so common infection now in your developed countries. I mean, your USA and Europe in your settings.
Come again. What about Candida aureus?
Is it one of the presentation I mean, you have seen in your ICU unit, in neonatal ICU units? I mean, we know well now, I mean, something that is common now in USA and in some of the developed countries.
Yeah, well, with embarrassment, it is actually got a tubercle that has got just babies with C. auris. So, I mean, our census, a number of babies that we have in the unit on average, we've got about 180, 190 neonates admitted just on the maternal side. So when we look at that number, we've got an area which we call a C. auris area. So currently, we've got about 4 babies on a ventilator in the C. auris area. And the other side, the high care area with C. auris, another 4 babies. So we've got about 8 babies. Of course, those are not babies that have got infection now. It's an accumulation, because once a baby's got C. auris, he stays or she stays in that cubicle or in that ward for life. Well, sorry, while he's still in the hospital, so until discharge. So hence the numbers are just highlighting the problem, but they are more talking to prevalence rather than talking to incidence. So we do have outbreaks now and then. So when we do, I think there was a nice paper from FITA, which was led by Professor Nilesh Govender, which talks about C. auris and how to deal with it and what to do when you have an outbreak. So we're sort of guided by that paper in terms of what we do in terms of surveillance or what we consider as an outbreak. I think we are labeled as a red zone or the red area kind of hospital in terms of C. auris. So in short, yes, C. auris has overtaken Candida parapsilosis, has overtaken Candida albicans. It is the #1 Candida species in our unit amongst the group of Candidas, but it's not #1 common pathogen in the unit. The #1 common pathogen is Acinetobacter baumannii, closely followed by Klebsiella, and sometimes those two, they change. Other month is more Klebsiella, other month is more baumannii.
Yeah. Okay. Thank you very much. Thank Dr. Mashego. Thanks for your comments. And Prof, just before we close, there's a request for slides. I don't know if you want to be able to share them or not.
So I will share with them, but I'll just have to take out the BARA data. Then I'll share the rest.
Yeah, you just send it to me.
Yeah, I will send it through to you. Sure.
Okay, thanks so that we'll then share that. Yeah. No, just for me to thank you very much for taking your time once more. As usual, it's always been a great time to listen to you, share your knowledge and experiences. And as you said, you're not an expert in infection control, but you're quite an neonatologist and work with quite a number of babies who do get infections in their units. And just want to say thank you very much for offering yourself. And thanks to all the colleagues who are here week in and week out, and we sure that you'll even join us again next week. We'll be discussing the pneumonias next week. It's just no fitting follow-up from this topic in terms of infections. And thanks to Gamo, background working from marketing team and the other colleagues who are in the marketing team who are helping us quite a lot with planning for these presentations. And sure, people don't want to go home tonight. Luleka, I don't know if you want to say something, but you want to close and say good night before we maybe I don't want to leave you out. Luleka Mhlawuli?
Sorry, Doc. I was actually clapping my hands. Thank you.
Oh, okay. Okay, but this we got to hear your voice. Thank you very much, colleagues, and have a good evening. Sure. See you next week.
Thank you for the opportunity.
No, thanks. Pleasure. Thanks, Dave.
Bye.
Bye.
Thank you.
Thanks, Socrates.